Not so long ago, the only choice for care outside of the home for someone with Alzheimer's was a nursing home. Moving to a facility designed around the special needs of Alzheimer's patients wasn't even an option. Today, though, a growing number of specialized facilities offer excellent care for people with Alzheimer's disease, particularly in its later stages. But the great majority of Alzheimer's sufferers, around 85% of them, remain in their homes. It's where they feel most comfortable. And in spite of the hardships of caregiving, it's also the choice of most families. There are a growing number of good resources available to support you in the difficult job of caregiving. And there are valuable skills you can learn that will help you better communicate with your loved one and organize a daily routine at home.
There are a lot of people that want to stay at home after a diagnosis of Alzheimer's disease, and that's very appropriate. The majority of people with Alzheimer's disease are at home. Only 10 to 30% of people with severe disease end up in a nursing home.
In the earliest stage, we put gate in all the, just like a kid's bed at home, we put the gate blocking all the staircase. So because she fell down once, fell down the stair. And the door would put alarm, so if she opened the door, somebody will hear that she's trying to go out. And we will not let her smoke anymore. So the quitting smoking was, I guess she had no longer feel the need to smoke. Even all her life she's been smoking.
We built this house with the plans of having both of them live with us. It's ironic that I really thought at that time I was going to be taking care of my father. He died before the house was completed, and she hasn't spent a day alone since the day he died.
At some point, many people become too frightened to stay alone. Some people stay alone much longer than they should. The general guidelines that I tell families about how long someone can safely be left alone is based on 4 basic activities. Can they answer the phone, and can they call at least one person in their family network? Can they reach somebody that they need to reach? Can they take medications and food appropriately? Can they safely negotiate their environment, get outside, go places that they have to go without getting lost or getting scared?
Her pathway is really pretty limited. The living room is right off of her bedroom, and the kitchen is all open to the living room. And truly, those 3 spaces are probably her world when she's home.
Initially, visitors were very helpful for my grandmother. She enjoyed receiving visitors, but as time passed, I think it became more disrupting to her because she couldn't quite put the face with the name, and you could see the struggle. And so we would read her body language would tell us how far and what can we do, because we wanted to keep her stimulated and wanted to introduce new opportunities every day, but we had to be careful not to push that and inundate her with more information than she can really process.
If we have too much stimulus going on or too little stimulus going on, we can create a situation where the person has behavioral symptoms. So what that would mean is, 1, keeping the noise down. And noise isn't just hearing noise, it can be the clutter in the environment. Patterns that are very pronounced, very geometric, very fast, repeated patterns can create a sense of agitation. If you've ever been around wallpaper that's too busy or too many bars, can be perceived as, if I don't understand that that's wallpaper, can be perceived as being in jail. If it's way too viney, very pronounced vines, it can look like it's moving to me. So of really looking, if you see a person becoming antsy, what's going on right now for them? Is there anything in the environment that's contributing that to them?
One of the things that I would encourage people to think about is to have a home assessment of physical issues that may be a problem. Maybe it's the doorway coming in, maybe it's what's on the floor, if there's scatter rugs or loose rugs, maybe it's having too many objects in the room, knickknacks kind of thing, too many books around, too much stimulation. For the most part, an Alzheimer's person is going to function best in a very very calm environment where there's not a lot of change.
We have a lot of books in the room that was the bedroom. One whole wall was shelves of books, and he liked books, and that was, at first I didn't see that as any problem, but then it got to the point where he would begin to tear pages out and put them aside. Sometimes he would take a magazine, that didn't matter, you know, looking through the magazine, but then he would take the books from the shelves and tear pages out. So we finally wound up boxing all the books and putting them away in the basement, and then eventually that room came like a, you know, mini hospital area with supplies that were needed for him, so it worked out well.
She had hardwood on her floors, and naturally most do have throw rugs, so they had to come up. We adjusted the water temperature so that she would not scald herself should she, as she had already done before, gotten into the water. Cabinets, you can put some little locks on them, particularly with cleaning products. We would do that.
Basically, you're child-proofing to 6 to 8 feet high, making sure that the outlets are covered with outlet covers, that there's no sharps, no toxics, that anything that's sharp or toxic is locked, that there is a way that the caregiver will know if this person with dementia starts to go into an unsafe area. You don't have to buy $4,000 alarm systems for your door. You can go to Radio Shack or another electrical store and get an alarm that rings anytime someone opens the door. So you can make it safe for that person to move around within their environment without having to constantly tell them no, they can move. The same way with an outdoor area. Creating it an area where there's locks on the gates so they can't get out, that the fencing is so they can't climb over. The person can be outdoors as long as they're well hydrated and in shade. Other outlets for moving, that needing to be constantly in movement, one of the best approaches is a rocking chair glider. Because I can be in a rocking chair glider and I can move all day long, but I'm not spending as many calories, I'm not going to fall. But I still have that outlet and that control of being in movement.
One woman became very obsessed with the iron. She wanted to iron everything, and she kept leaving the iron on. And she felt like things were always damp in her house and things were never dried out. So she would iron them, and she would also put them over the burner. And she eventually started a fire.
And bedtime, she was pretty good about going to bed, but she would be up at night, and that was scary. We took little baby monitors, put them throughout the house, keep the doors open, put a bell on the bathroom door so that we would hear her waking up. But again, just the disturbance of sleep after a while, trying to maintain your own schedule is grueling.
If the individual has a tendency to want to cook, then you may need to unplug the stove, turn off the eyes, fix it so they cannot turn on a stove when you've happened into another room. The car keys, anything that they might be able to injure themselves with, you want to put away. You may need to lock the doors to the basement so that they're not able to get down into the basement or into the garage, any place where you keep your lawnmower or your weed eater or things like that. You want to do any sort of safety proofing just like you would for any older individual, so throw rugs and cords need to be taken up, and you need to look at how the bathroom is set up and the bedroom is set up in terms of clutter and being able to get through the house. Sometimes putting signs on the rooms, this is the bathroom, this is the kitchen, this is the bedroom, may help orient them so that they don't go into the wrong place.
We used to think that there were a whole lot of magic bullets. There really isn't any magic bullet. The idea that if I don't want you to go out the door, I put a stop sign on the door. Now think about it. When you come up, when you're driving and you come up to a stop sign, what do? Do you stop and stay there? Do you stop and turn around? No. If you obey the law, you stop and go on. So stop signs really aren't very effective. What is effective is reducing that stimulus of that as an exit and creating something more important that I want to be involved in here. There is some research that if you want them not to go to an area, you might put something that looks black or dark on the floor, and that is true. Or even the reverse is true. If you wonder why your loved one won't come out of their bedroom, and you look down and the rug and the carpet has a gap between it that looks like a step, they may be afraid to come out because they're afraid they can't go down that step. They may misperceive it. Or if they live in a residential setting that has long hallways and lots of bright lights, and they look out there and it's high gloss floors, they may think the floor is wet and they'll fall. So if a person's resisting going out, look at, is there anything right now looking with their eyes that would frighten them? Anything that would make them feel uneasy, and try to work around that.
You can't always think like someone with Alzheimer's disease, so you can't anticipate and prevent all bad things from happening. An example of that is one family I know dismantled the stove, and when it didn't work, the woman collected wood in her yard and started a fire in her stove to cook. So you can't always think exactly like someone with Alzheimer's, and there are dangers.
Let's talk now about driving. For most of us, driving is part of daily living. It's also a mark of our independence ever since we were old enough to get a license. But for someone with Alzheimer's, driving poses special dangers. Sometimes it is hard to help our loved one realize it's time to give up the car keys, both for their sake and for others on the road.
Taking the car was probably the hardest thing we had to do. And to alleviate the problem without going into why she could no longer drive, we took a plug out and said that it needed to be repaired. And she really understood that, and it created more harmony than harm.
He had a couple of minor accidents that seemed like, there was no reason for it. He was losing his sense of judgment somewhat. Judgment of space and distance and that, and we just had to put the car away. And when he looked for the keys, well, at one time we couldn't find them, and then after that we put the car out of sight, and finally he got used to the idea of not having it.
Driving in American society is a mark of independence. Losing the privilege of driving is a very big loss, even in a demented individual. Most individuals with a dementia will voluntarily reduce their driving. They may not stop, but they will drive shorter distances in familiar surroundings during daylight hours when there's low traffic volume, and often do all right.
Driving is probably one of the most difficult situations because it's how long have these folks been driving? Some folks have been driving 70 years, 65, 70 years. For many people, it has become as second nature as walking. Like us, we'll get in a car and just start driving, not even think of the mechanics of doing it. So you can continue to actually physically drive a car long beyond the point where you know where you're going. And you might just get in there and drive until you run out of gas. At the point where the person starts having episodes of being lost, of not being able to find their way home, of having to use, one man I worked with, on the inside of his visor had the directions back to his house, and on his dashboard and the steering wheel had the directions to his church that he'd gone to for 60 years. At the point that it's becoming that difficult, it's still early in the disease, you might be able to rationalize with them, I think you're having difficulty, Dad. That may not work. If reasoning and explaining doesn't work, you might ask the doctor to intervene. And you can have the doctor to intervene saying, John, I really don't think it's safe for you to drive any longer.
Bring the individual to the doctor's office for a physical, but alerting the physician to the fact that driving is becoming a problem. It's not safe. And such things as a request to have the individual take another driver's test, knowing full well that they'll never pass it, may be one option. The other may be a frank discussion with the physician as an authority figure to get the individual to give up driving. And both techniques are very effective and work.
In many states, if you notify your the Department of Motor Vehicles, they will send a letter to that person and ask them to come in for a driving test. So then the Department of Motor Vehicles can take the driver's license away. And the final thing is to disengage the car, to unplug the starter, disengage the car, hide the car keys, or sell the car. Once again, this is the thing where it's totally based upon the individual, and you have to weigh, just because I have a diagnosis of Alzheimer's doesn't mean I can't function. That doesn't mean but at what point does the risk outweigh the benefit of having that car?
And it is very common for the earlier stages of Alzheimer's disease to permit driving, sometimes with supervision, sometimes with some restrictions such as staying close to home and driving during daylight hours. But as time goes on, the ability to drive lessens. And most of the time, in my experience, 99% of the time, the individual realizes this and actually ceases driving on their own. They're actually frightened to drive.
It's hard to see people with Alzheimer's for what they were because of how the disease affects their behavior now. But keep in mind that our loved ones are, after all, real people who've done amazing things in their lives. It's important to remember that and to treat them as adults, even if their actions create a temptation to treat them otherwise. For many caregivers, the most difficult part of our job, even more than providing for our loved ones' physical needs, is dealing with their behavior. On the one hand, we have to try to view behavior from our loved ones' distorted sense of reality. It can be like attempting to reason with a very small child. On the other hand, though, always bear in mind that while Alzheimer's-related behavior may seem childish, our loved ones still feel the same adult emotions.
And if you realize that they're in a situation that's not of their making, and try to make things as normal as you possibly can for them, like treat them in the same way. Don't talk down to them, or don't try to act like a boss of theirs, giving orders. You have to be sort of a super diplomat in your approach to them, and let them know that you're considering their feelings, even if you don't see the response as what you would normally expect. You have to treat them like that anyway, so that if it is getting through at all, it's a positive thing that's getting through, because they're very sensitive to the sound of your voice, to the inflections. If you are angry, then they'll respond with anger, So you just have to treat them basically the way you would want someone to treat you if you happen to be in that situation.
It is difficult sometimes to remember that you are dealing with an adult because they're acting so childish at times. I find that one of the things that has helped me is looking back at home movies when she was a real functioning person, looking at pictures and remembering times, because when you're in the thick of it, it's hard to remember how things were. It hasn't really been that long, but it seems like an eternity since I've been able to have a conversation with her.
I resented so much when anybody ever said, she's like a child, or my sister even said that. I took such a strong reaction to that because I felt as though it was demeaning, it was pandering, it was the old attitude of, we know what's best.
I think it's very important for everyone to understand that an Alzheimer's person loses their ability to think, their cognitive abilities, if you will, but they do not lose their emotions. They have the same feelings that everyone else has. They can be sad, happy, angry, frustrated, or whatever. So it's very important that we help our families learn to communicate through those emotions and to connect with somebody through those emotions.
These people may behave like children, but they are very aware that they are adults and very sensitive to being treated like children. It's very important, even if the behavior appears childish, to treat the person as an adult with an adult history and to respond to them in a dignified, respectful manner, even if their behavior is not dignified. Some people appreciate nurturing and coddling, and that's sort of childlike. Some people are also reassured in childlike ways. For example, many people in nursing homes like having stuffed animals and dolls to hold, and they may think that they're real babies. And it may be very reassuring to them to have something to hold and cuddle and nurture. And that's adult and dignified from their perspective, and that's okay.
It does rob a person of some of their abilities to do things, and it does make them revert in some ways to earlier times when they developmentally could not do these things. But as a child has the ability to grow and learn from their mistakes, an Alzheimer's individual does not. The disease has taken away that ability.
I knew that a lot of people related childlike behavior to this disease. I rejected it because it was, this person, a child is always growing, is always learning. This person is, not only can they no longer learn new behaviors, I mean, I couldn't even, in the beginning I would get so frustrated because I would try to show my mother how to turn on the faucet in the tub, for example. And I didn't realize that she couldn't learn new behaviors.
They also are an adult with a history, with a past, with all the accomplishments that they've had, and it would really be doing them a disservice to treat them as a child. You really want to remember that this person is an adult and has accomplished many things as an adult. If a person's in a nursing facility, it's important to have a picture or something that indicates what that person was like in earlier years. Part of this is also getting at meeting them at their reality. A lot of times family members want to bring in pictures of what they look like now, but that may not be their reality. If you show them a series of pictures and they point to the one when they were 30 years old, then that's probably their reality. They go, that's me.
Someone once said, the most important thing about Alzheimer's care is to park our reality at the door. So when you think about when you're working with a person who's in the middle to late stages, they can't bend their mind to understand our reality as it's around us. But we have the ability to bend our mind to accommodate their needs and to relate to them in a way that works for them. You'll hear people say that folks with Alzheimer's are like children. They're in no way like children. Their perception of what's around them, their understanding of objects might be similar to a child that's 3 to 7 or 8 years old. That might be happening, but they have a lifetime of experiences. And not only that, but they are adult emotional beings. They're people who need to be in control, who need to have relationships, who need to give and nurture as much as they are given to and nurtured to.
One of the key skills, many experts will tell you the key skill in caring for someone with Alzheimer's, is learning to communicate effectively. And that's not easy. Our loved ones may have only a limited ability to express themselves, and we have to work extra hard to make ourselves understood to them. But gradually we can learn to do it through practice and by following some pretty basic strategies.
My communication with her just as she understands. And I do believe she does, and she just cannot respond back to me. And also because she cannot speak, so I had to anticipate her feeling, her physical and emotional feeling all the time. And I will ask her, and I will just keep on put myself in her shoes, her position, say how do I feel, how physically this is comfortable, or what will make me happy to hear right now.
He lost the power of speech at some time along the way. Toward the end, he didn't talk a lot, and then along the way, his speech was not quite English. there were times when he would say sentences that sounded like he was speaking another language.
I usually say something once, and if she doesn't respond, I'll make sure she's really looking me in the eye and say it again. And if she still doesn't understand, then you phrase it somewhat differently. And one of the things I found before we got to this point that was very helpful is nouns were what was difficult for her. She didn't understand what an object's name was, but she knew its function. And you could say, describe what it did, and she would understand. But she didn't understand what the name for the word was. And that we just kind of learned. So we describe everything as we go along. And some things you just have to do with motions. Fasten your seatbelt, and you make the motion and show her. And sometimes we just have to do it because it still doesn't register. And other days she'll get in and just snap it.
When it came to how do I know when she's going to the bathroom, only occasionally could I see something in her face. But most of the time it was, you just do it on a regular cycle because we couldn't. I didn't know if she was in pain. And that was so frustrating and so hard.
We tried to keep it very simple. We would ask, would you like to have vanilla ice cream or chocolate ice cream? Do you want to wear this outfit or would you like to wear this one? And we found again that kept her dignity and allowed for her independence as much as possible without overwhelming her with lots of stimuli and lots of choices.
We went to look for him. It was early, but he hadn't come home, and we found him in a park in a high school area where they played games, but he was beyond this, and we saw him and we walked up and we found him. And my neighbor said to him, "Alan, what were you doing way up here?" And he said, "Oh, I was just strelling." So we used to tease about that. Well, I guess I'll go for a strell. But that was one of the words that he coined for himself. And then, as I say, sometimes he would say things that you wouldn't understand at all.
Caregivers' ability to understand and to listen and to try to understand what that Alzheimer's patient is saying is a real significant part in keeping someone at home for a long period of time.
The person with Alzheimer's or dementia might have difficulty expressing what they need. If I need to go to the bathroom, I may not be able to find the word in my mind, bathroom, so I say, I have to, and I can't find that word. So we have to rely on their body language, and we have to rely on our body language to get messages across. The other thing that may happen is the person misidentifies an object. You may hand them glasses for them to put on their head, to put on their face to read, but they pick up the glasses and they misinterpret what it is, and they try to comb their hair with the glasses. So those are some of the challenges that we're working with, is the loss of identifying objects and understanding language.
Verbal communication may become less and less as the disease progresses. Eye contact, facial expressions, touch, personal closeness are all ways to communicate. I have an individual, a gentleman who requires assistance and supervision by his wife all of the time. He follows her around like a puppy, she says, and she'll sometimes turn around and find that he's several inches right in back of her. At first that might startle her, but then she realizes that he wants to be close. He's lonely, or perhaps he needs something. He may be hungry, and she'll have to try to get the information by asking questions or remembering the context of where they are as to what the need might be.
There's some probably simple recommendations that are helpful. Using short, simple sentences. Don't get it too wordy. Don't give them long explanations. If you want them to make a choice or do something for you, don't give them lots of choices. Don't say, what kind of juice do you want, but say, do you want apple or orange? Or do you want orange or grape? So you give them very simple choices when you communicate. asking them to do things one step at a time. So breaking down tasks into very simple one-step commands. You know, put on your sock, put on your shoe, you know, fasten your belt, just one step at a time. Speaking very softly and not rushing up on them, not approaching them from behind, but approaching them from the front, being reassuring and with your speech is important.
And looking at communication, sometimes people will take what we say very literally. If we say, "Oh, I'm so hungry I could eat a horse," they may think that we're going to have a horse for dinner because they lost the ability to understand like I could or as if I could.
Using motions to help you communicate. They may not know if you say, pick up your fork, but if you put your hand on their hand with the fork, they may remember and be able to do that. So I think using other things besides just verbal communication is important. Thinking about your body language and reading their body language will help you communicate with them too. If they're beginning to tighten up and get tense or start fidgeting, you may need to use distraction or some sort of technique to settle that down before it becomes a problem. So it's verbal and nonverbal communication.
I worked with this one man who lived in assisted living, and he would get very agitated and say, I've got to find Claire. Do you know where Claire is? Do you know where Claire is? Where is Claire? Where is Claire? I've got to find Claire. When we became very concerned, we realized his wife's name was Sally, and he had no female relatives. So we were wondering just who Claire was, but he was very upset looking for Claire. His brother came to visit, and I asked his brother, do you know who Claire is? He said, Claire? He's not asking for Claire, is he? And we said, yes, he's asking for Claire. And I can't believe he's asking for Claire after all these years. Are you sure he's asking for Claire? Yes, sir, it's Claire. He goes, I just can't believe that it's Claire. I said, sir, can you tell me who Claire was? Claire was his pig. And he had raised a pig for 4-H when he was 12 years old. And in our mind, we thought Claire was this other woman. Claire had nothing to do with another woman. It was something that needed him. He, in his mind of where he was, there was something that he was responsible for, something that needed him, something that he had to take care of. Now, we couldn't, in an assisted living, bring in a pig. But what we could do is, kind of symbolically replace what it was that he needed. And he needed to take care of something. And we had a house dog. So he became responsible for feeding and combing and grooming and petting that house dog. And we had to find as many tasks that he could take care of, that people depended upon him to help meet that need, to reduce that anxiety about finding Claire. Now, what did happen is he started calling the dog Claire.
I went for a little trip one time for 4 days. My daughter took care of her dad, and I came home, and he came, as I was coming in the door, he came to the door, and I greeted him, I hugged him, and I said, did you miss me? And he said, no. And I said, why did I ask that question? But later in the evening, I was sitting in the den, and my daughter was sitting in front of the door, and my husband walked in. He spoke to my daughter, and he was leaning over her saying something, and then he turned around and he saw me, and he smiled, and it was one of the old smiles. He looked like himself, and he turned back to my daughter and he said, look who's back. And neither one of us could believe that he had said that.
As we learn to cope with Alzheimer's-related behaviors and to communicate more successfully with our loved one, we're better able to establish more of a daily routine to reduce some of what may seem like utter chaos. And that's a valuable gift, not just to ourselves, but to our loved ones as well. Having a structure to their days is important to Alzheimer's sufferers. At the same time, though, I've learned through my own experience that it's equally important to stay flexible, because as is true with so many things about this disease, nothing is as predictable as its unpredictable effects.
learn to be able to adapt because everything's going to change. It's important to set up a routine and make whoever you're caring for, their day be as routine as possible. Have their clothes sitting in the same place every morning when they wake up. Have their breakfast in the same place. And my mother eats the exact same cereal every morning. And she recognizes that box, and that's what she eats for breakfast.
To cope with Alzheimer's disease in the home setting, people need to establish a structured, predictable routine, a relatively safe environment that allows some movement around, places to walk, an outdoor access if it's protected or fenced in, and a structured, guided, cued activities for their relative. Most people need breaks at regular times when they can just sit and stare out the window. Some people can spend hours listening to music, watching old videotapes of familiar, comforting themes. Many families find they have to turn off the television set because television is easily misinterpreted.
It's also very important that we have activities for somebody with this disease. This isn't a disease where you just put people into a chair and let them fade away. There are lots of things that an Alzheimer's person can continue to enjoy. Maybe they were an avid bowler and they would like to go bowling. Who cares what the score is? Or golfing, if maybe they were an avid golfer, and arrange for them to have someone to play golf with.
Well, a routine day would be to wake him up and get him cleaned up, take him in the bathtub. That was like the pretty much of an ordeal of the day, but we would get through that. Clean clothes, breakfast. Maybe we'd go out for a walk, come back. He liked to listen to music. Sometimes he'd look at TV, but not too much. And talk. He liked to do things with his fingers, with his hands. And one day he had been hospitalized, so we had a visiting nurse who would come often, and she brought a child's toy. Actually, it's almost an infant toy, but it has beads on it, and it's all these different colors, and he just loved that, to work with that, play with that.
Looking at what we're trying to do is to help that person be successful every day. And being successful every day, the most important thing is I feel good about myself. That's the most important thing, is today, can we help this person with Alzheimer's feel good about themselves? Can we help them have a relationship with other human beings? The most important thing is not, do they get a bath? Do they have the right shirt on? So it's kind of opening up our minds so that we're a little bit more flexible and open to what's appropriate where, what's appropriate actions on their part.
For a while, we got to where we put the cereal bowl out and the cereal out and set everything out, and then she could put it together. Now it's gotten to where she can't even do that. So, as time goes on and you realize things are changing, you adapt as you go on. I've tried as much as possible to allow her to do things for herself until she couldn't do them any longer, because it's frustrating for her too.
The other thing is that what works today may not work tomorrow. What works now may not work 2 hours from now. What works when I do it may not work when you do it. So the most important thing is to be patient, take a deep breath, and be flexible. Just kind of hang in there and find out what's working right now.
Getting her up, getting her dressed, giving her breakfast. Maybe we would go out, maybe we wouldn't go out, in which case, when she was still mobile, as I said before, she wouldn't sit still, so she was just kind of always popping up and down. And even that, I would try to put my own idea about what she should be doing instead of just relaxing with it. And she would pace a lot. She would just kind of pace. Sometimes she would, be gibberish, and sometimes she would be upset. And as things got worse, as she became incontinent, then I became there was less of a desire on my part to even take her out because it was selfish of me, but it was too difficult. Getting her inside and out of a car became difficult because her body started to become more rigid.
I now have to put everything on her plate for her and cut her meat up for her. She still can feed herself, but at some point I figured that's probably going to be another change too. But you just have to take it a day at a time, really.
As the disease progresses, the biggest part of our routine each day involves the tasks of helping our loved one with all the basic activities of daily living. As anyone who's been a caregiver can tell you, it's also the most physically draining part of the day, and it can leave you emotionally exhausted. In our next program, you'll learn how to make these daily tasks more manageable, more effective, and much easier on you.
More often than not, families postpone the decision to look at long-term care until their loved one experiences a crisis or can no longer take care of themselves. But the best time to explore your choices is well before you're forced to make them.
I cannot emphasize enough the kind of communication in which we learn the wishes of the individual for whom we're caring.
There are a number of warning signs you can watch for. One term you'll hear frequently is ADLs, activities of daily living.
Another trigger may be that there is particular, what we would classify as bizarre behavior.
The children are in denial that dad needs help or mom needs help. And most of those classic examples are usually people that have memory loss and Alzheimer's type dementia.
It's important to have that assessed and not just assume that they're getting old and so their memory's not good. That is not true.
We're all bounded by limits from the standpoint that even though we see need, even though that we see unmet need, that we may have to start not with level of care change, but start at a lower level with what a parent will accept.
Determining which option is best for you depends on several factors. First and foremost, the extent of your loved one's physical needs and abilities, your family's financial situation, and your loved one's preferences and your own.
The good news is that families have lots of options today. The bad news is that there's often some confusion on what those options really are.
Simple medication instruction, teaching families what are some of the side effects of medications, what are the usual schedules for medication.
There are a lot of devices that help people still continue to use their hands that have aged and aren't as strong as they used to be.
There is no shame in looking for other settings and other relationships.
Talk to your loved one in a respectful way that makes them feel part of the decision.
If you and I were uprooted in the midst of having medical problems from a home that had many memories that our children grew up in, or that we had very special things that to us were a part of our memory and history, and all of a sudden we were plopped somewhere else, it would be a catastrophic kind of reaction and agree.
If you are truly at a place where you can no longer provide the best care for that person, you're making the most kind, loving, and ethical decision to go on to the next step. And your responsibility there doesn't end, but it changes.
Many times you hear about guilt on the children's side of things when they move someone to assisted living, but a lot of times the resident also had guilt by feeling like they may have been a burden. The biggest difference between independent living and assisted living would be someone that might be ready to make a change. Maybe the water heater's gone out for the last time. There's quite a few widows and widowers that, especially the widowers, that were not accustomed to cooking for themselves all the time, and just like the support services.
And the biggest word of advice we have for couples, a husband and wife, that are looking to move out of their home and into some type of a community.
In an assisted living community, residents receive the help they require with activities of daily living.
Aging in place assumes that we build in the support that's needed in an appropriate fashion as conditions and as the aging process itself present opportunities to make life better for that individual.
There are 2 levels of nursing care, and many facilities offer both. Skilled nursing care.
Be very picky. Be very picky. It's very difficult to make that first move. It's even going to be more difficult to make the second move.
But it's also important to go at some unscheduled times because you want to see what's going on in the evenings or what's going on the weekends, because typically staffing patterns are different.
There is no substitute for a loving, trustworthy, empathic individual.
How they structure their day, what kind of activities they have, what kind of staffing ratios they have. Do they have a nurse on site? How do they handle emergencies?
At the same time, they want the CNAs in the facilities to realize who they're dealing with, that this is your husband and he was a banker and he loved to ski, and to humanize your loved one.
The pharmacies usually will package it in what they call bubble packs, and to find out maybe they cannot swallow certain types of pills or certain capsules, or can they be opened up and put into Jell-O or to applesauce. If that's what was done before at home, then maybe that's what you need to be able to emphasize also to the people at the facility.
They still know their family member better than anyone else, and that, in fact, it is their responsibility to maintain an alliance and a partnership with a care facility.
Nursing homes are the most highly regulated healthcare industry in this country, and they have very stringent requirements related to that. However, that does not always translate to high-quality care.
They need to be very bold and very specific in knowing what's going on in an environment where a loved one is placed.
Many Americans are looking at long-term care insurance as a way to preserve choice, protect their assets, and reduce the burden for family caregivers if the need for care arises. Medicaid is a joint federal-state health financing program for low-income individuals.
Depending on a person's age and their sex, their health, they may live many, many years needing some type, if not complete, long-term care. So having that insurance policy for peace of mind, if nothing else, for many people is quite helpful. Many children are beginning to look into long-term care policies for the same reason.
Some people think that buying long-term care insurance can be quite complicated, when in essence there's basically 5 decisions that you're going to make.
It's important to have a comprehensive policy that offers benefits across the care continuum, meaning home health, other community care such as adult daycare, assisted living, skilled nursing facility, who knows what will come in the future, whatever the continuum is, so that the person has choices, because really the crux of long-term care insurance is asset protection and independence and choice.
Then that policy is going to allow their caregiver at home to have help come in on a regular basis to give them the relief they need to provide care for that individual for a longer, more extended period of time.
There are 3 important legal instruments that address these issues: a testamentary will, a living will, and a durable power of attorney.
Now, in almost every state, even if there's no will, the property is going to pass to the spouse and then the children. It won't go to the state, which is what a lot of people are afraid of. Oh, if I die without a will, it's all going to go to the state. Property only goes to the state.
The living will is really a communication device to your family and to your providers, healthcare providers, your doctors and others. These are my wishes. I'm writing this down and putting it in a form that I want you to respect.
80% of people who die in America die in the hospital. Many of those deaths occur in intensive care units. Some of those deaths, about 15% of them, occur after the patient their heart has stopped and we've attempted to resuscitate them.
A durable power of attorney is another important means of making sure your wishes are followed.
A durable power of attorney for health care is another legal instrument that allows a person, whether they're terminally ill or well, to identify another person.
It is a good idea for people to have the living will, the durable power of attorney for health care, and the general or financial power of attorney to cover all financial matters.
Generally speaking, when people get to the place where they have to make decisions about long-term care, financial decisions are the last thing that they want to be dealing with.
It's almost a skeleton binder that the parent or the child can have as a starting point to say, I've got to find this document, I've got to find this document, and it's a place to where you can store everything.
You don't immediately assume that what you're looking at is simply a document. It may actually be the asset itself.
How much will you need to spend? To answer this second question, you'll need to do a little legwork.
What most people end up dealing with is, how do I make my money stretch far enough?
For most of us, Social Security is the first financial resource we think of when we plan for our retirement years. But the benefits are not the same for everyone, and not everyone qualifies to receive them.
The spouses may want to check and see whether it would be more beneficial to draw their normal Social Security benefit.
In the distribution phase of a retirement plan, you really have to be aware of the income tax associated with each retirement account. The money that is set up for the fixed income side is set up in a way that you have a consistent flow of income, whether on a monthly or a quarterly basis, to where you can keep up with the inflows.
Part A pays for hospital care, a limited amount of nurse. Medicare Part B pays primarily for physician charges, though it also covers. Medicare benefits are based on a complex table of charges that the government believes are reasonable.
When a physician accepts assignment under Medicare Part B, they are accepting the Medicare-approved charge as payment in full. But a Medicare summary of coverage basically gives you an explanation of what charges the doctor has charged based on the given percentage. In addition to traditional Medicare, the federal government has created Medicare Choice.
Since Medicare doesn't pay for everything, many people buy supplemental coverage.
In the early 90s, the federal government standardized those plans, and there's now 10 plans.
The emotional aspects of caregiving can be extremely complex and uniquely personal to each individual. But in talking to caregivers, we have found they have many concerns in common. In fact, coping is the one topic that seems to be the most difficult for caregivers.
But I think as a nurse, I also feel like I should be able to do a better job of what I'm doing. And I don't mean the physical kind of things, but I mean dealing with the emotional part of the role change and the emotional part of seeing my mother declining.
To sit down and make a list of, these are the things that I feel comfortable with, that I feel like I'm handling okay, and these are the areas where I'm feeling overwhelmed.
Feeling confused and pulled in several different directions is a common complaint from caregivers. Demands from work and family, plus those created from the caregiving process, may make you feel like you're not able to satisfy everyone or anyone.
I wanted to please her, and I wanted her to be happy, and I wanted her to feel well, and when I couldn't make her happy, it was just very difficult for me.
Because it's not his fault and it's nobody's fault. But you're angry because you say, why? And some days that he's more confused than others, and you lose your patience. because you need a lot of patience with the disease.
People really set themselves up for physical health problems, mental health problems, when they try to do it all themselves. And it's a very dangerous position to be in, because ultimately you're putting your loved one at a greater risk.
I was really becoming emotionally exhausted, was that I couldn't do the things that I love to do, and I had all this time to do it. I had all this free time to write, read, create, and I couldn't do it.
Before you can take care of someone else, you have got to take care of yourself. You have got to get up, and as much as you can, at least have that shower, get dressed, and a few minutes to yourself before you can take on the care of someone else.
Profound levels of self-care are needed in order to continue caregiving, and hard decisions like putting yourself first becomes necessary in order for you to do anything at all. And I think it's really hard for persons to make that switch and to realize that, in fact, what has all along been seen as the non-loving thing to do is now the most loving thing to do. Because if you can't maintain your own strength, then you can't be there for that person.
Whatever matters a whole lot to the individual to whom the care is given. And if it is not endangering his health, that he ought to be permitted to do it, even though the observer would think that it was stupid for him to do that it was childish or selfish or whatever. And you would think of it that he would have only some X number of years to live, and he might as well live those happily.
Fold each side of the washcloth across the palm of the hand. Now, fold the top of the cloth over the palm and tuck it under the edge. Using long, smooth strokes, wash from the wrist to the upper arm. Then bend the patient's leg on the bed and place the foot in the wash basin. Place the shampoo basin or inflatable sink under the patient's head. Using a pitcher, completely wet the patient's hair. Use warm water ranging from 105 to 110 degrees Fahrenheit. Select bedding that is lightweight, soft, and washable. Synthetic fabrics are often too hot. And starting at the head of the bed, strip the bottom sheet, draw sheet, and linen-saving pad from the unoccupied side of the bed. Roll the sheet tightly against the person's back or side. Bedridden patients should, if at all possible, be placed near a window with a view. Also place a large calendar and clock in the room. Devices like a mechanical lift can relieve much of the physical burden. First, let's learn how to safely transfer a patient from the bed to a chair. Bring your forearm to your chest, drawing the patient to you. Hold the patient's inside hand with your outer hand. This position gives you good control of the patient. Observe your home with a fresh eye for obvious dangers. You may also want to purchase a waterproof bench or chair to place in the shower or tub so the patient can sit while bathing. Always speak to the patient as an adult in a clear and respectful manner. Also, talk to the patient as if you expect a response. Many patients can understand what you're saying, even if they don't respond.
I think everyone should have a list of all the medications they're taking, what is prescribed by the doctor, have the trade name, have the generic name written down.
Number 2, when supervising or administering medication, check for the 5 rights: the right medicine, the right dosage, the right time, the right route, and the right way.
One of the most important things that a caregiver can do, or any patient can do, is be familiar with your medicine, with what it looks like.
Single, most effective way to prevent infection is as close as your sink. It's called hand washing, while turning the glove inside out. With the inside out glove protecting your fingertips, peel off the remaining glove, turning it inside out and encasing the first glove. Always use disposable gloves when touching soiled linens, pads, wound dressings, or clothing. Nutrition plays a vital part in maintaining good health and preventing and treating disease. However, most caregivers soon realize that ensuring adequate nutrition for the patient can be somewhat challenging.